self-reported that is, presenting with diffuse rash and abdominal pain. Before we jump into the case, I want to introduce you to our expert, Dr. Bhandari. Just a little bit about her. She is an assistant professor of medicine in the Department of Rheumatology. She did her medical school in Nepal at Kathmandu University, did a residency at Danbury Hospital, affiliated with Yale University, and then just completed her fellowship in rheumatology here at WashU, graduated just a few months ago. Psoriasis and self-reported celiac disease, presenting with a diffuse rash and abdominal pain. Jumping into the history of present illness. So for reference, this patient is presenting at the end of January. So he notes that around Christmas time, his kids had gotten sick, and then he also got sick. He had an upper respiratory infection, notable symptoms just like sinusitis, postnasal drip, and a cough. And this was self-resolving, just took Tylenol and, rested at home. Few days after resolution of his symptoms, he noted development of a rash. The rash was bilateral, kind of insidious in onset, started on his feet and his calves, and over the following week spread to his shins, trunk, and arms. He was seen in an urgent care 1 week prior to his presentation to Barnes, and he got a course of prednisone and Augmentin, the UC special, without any significant resolution of the rash. He says over the month that he had the rash, perhaps some mild waxing and waning of it, but no significant resolution. What prompted his presentation to Barnes was he had a sudden onset abdominal pain, one episode of dark green emesis, and one episode of dark blue stool. So I wanted to pause here for a second and ask to you, what parts of this HPI really stick out to you, and how does that inform your differential diagnosis that you're developing for this gentleman?
I think the first one probably would be a history of a URI. Like usually a history of viral infection can precede a lot of inflammatory conditions. Stuff like vasculitis can also be secondary to that. Stuff like streptococcal infection sometimes can lead to a lot of inflammatory diseases. So I think that stood out to me first. And then since the rash was kind of like bilateral, starting from the feet up, that usually I start to think about, again, it depends on the type of the rash, but I would start to think again about anything like vasculitis related, like a purpura would be something that I would think of. And then the celiac disease, I know you coded it, but sometimes the celiac disease, dermatitis herpetiformis rash, can also be more in the extensor surfaces. So that's something that I would think about too. And then I think those would be the first two things that I would think about. Obviously, somebody with psoriasis could be developing a psoriatic flare too. And this could be a common place for that as well. So those two things usually pops up in my head. This history of prednisone and Augmentin course, not sure if that adds to my case. Maybe the prednisone helped with the waxing and waning. I'm not sure. Maybe that helped the resolution of the rash. I can't really think of an Augmentin rash helping the rash at this point, unless there was a bacterial superinfection, which is probably unlikely. And then belly pain, again, going back to the vasculitic etiology, usually when there's a tie between GI symptoms and skin rash, especially in the dependent areas of the body, makes me again think about a vasculitic process, or at least immune complex mediated deposition process. But then the vomiting, dark blue stool, obviously I would have to think about maybe some form of upper GI bleeding also associated with it. But like the vomiting could be non-specific. So I would think about maybe like a liver inflammation, like a hepatitis also tied in here. But those would be my initial thoughts, I would think.
Thank you so much for elaborating on your thought process there. Very helpful for us. What other questions would you like to know? I'm going to give you a full ROS next. But within that, are there any specific questions you would like me to answer regarding the HPI and ROS?
Yeah, I think fever would be something that I would still be interested in. Any constitutional signs, like constitutional symptoms, fatigue. And I would probably be also interested in knowing the children's URI history, like how long did it last? Was there a specific pattern to their rashes? Is there any mucosal involvement? Would also be something that I would be interested in. Before the prednisone and augmentin course, did you receive any like new drugs or antibiotics before all of this started? Would be something that I would be interested in. And how controlled has his psoriasis been? And what is this celiac disease history exactly? I would want to elaborate on that, I think, for history.
Great. So I'll give you the ROS first, and then I can answer the past medical history on the subsequent slide. Great. Going through his ROS, he has a lot of positives within his ROS. Negative for the B symptoms, no chills, fever, fatigue, or weight loss that he notes. For reference, his weight is 69 kilos with a BMI of 24. As regarding the mucosal involvement, he has noted over the last month occasional epistaxis with persistent nasal congestion after that initial URI episode around Christmas time. Pulmonary symptoms, no shortness of breath. He temporarily had a cough around Christmas time, but that resolved by January first week. Cardiovascular, he has no chest pain, no palpitations or lower extremity edema. GI is notable for the abdominal pain that predated his admission to Barnes. He had one episode of emesis and he's still nauseous in the ED, and he had multiple episodes of dark loose stool. GU symptoms, he has noted some urinary frequency over the last month without dysuria. Hematologic, blood in the stool, and rash, as aforementioned. MSK, he does endorse bilateral arthralgias in his knees. He digging through his history, didn't endorse them in other joints like, elbows, shoulders, fingers. Skin, he has the rash on bilateral legs, trunk, back, and arms. And yes, I will eventually give you a picture and a description. Neurologic is negative for weakness, numbness, and tingling, and psych is negative for depressed mood. I think the other questions you had asked were regarding his children's URI history. I don't know much detail about that. I know that they were feeling well at the time of the ED presentation. I think it was just like a standard self-resolving URI. I know that they did not have any rash or any like complicating symptoms after their infection. Was there other questions within that you had asked that I hadn't answered yet?
No, I think I had asked if there was any like new drug right before
Oh,
the
yes, new drugs. No, so he is on no medications. Within this review of systems, there's a lot of stuff that's positive in here, and I think it would be helpful for the audience and for myself if you could point out the things that are most pertinent to you and how that helps refine your differential from what you mentioned before.
I think there's a lot of important stuff here. Probably the rash, in my mind, would be the most important review here, just because the distribution and the nature, when she showed me the picture of the rash, would be something that helps my mind think of a diagnosis, since there are some classical presentation of diseases that you can see. The arthralgias are pretty non-specific. I'm not sure what I will, it guides me either way. The blood in the stool and the dark blue stools are something that I'm concerned about. Just because GI bleeding is concerning by itself. And if it is in the vasculitic territory that I'm talking about, then we're thinking like mesenteric vasculitis or stuff like IBD. So I would want to know more about that and make sure like his hemoglobin is fine, vitals are fine, and stuff like that. The abdomen pain right now for me, left upper quadrant, maybe a spleen involvement, maybe there's some like splenic infiltration or something like so that one is also an important finding that I see here. The occasional epistaxis and nasal congestion, again, could be a part of a small vessel vasculitis picture, but by itself does not really point me in any specific direction. I know that was whole lot of nothing, but I guess rash and left upper quadrant left upper quadrant pain, and then the concern for GI bleed are the three things that stick out.
Great. Thank you so much. Jumping into a little bit more about our past medical and surgical history. So he has a family history of celiac disease. His brother has antibody-proven celiac disease. However, our patient does not have positive antibodies or any history of being tested for it. He just hasn't eaten gluten in like 15 to 20 years. Psoriasis, he had a childhood history of relatively severe psoriasis. Couldn't find much about his history as a child, but I know that as an adult, he has only had a few isolated lesions over the last few years that have been managed with simple course of topical steroid. Surgical history, relatively not relevant. 10 years ago, he had a fall and fractured his wrist and had that repaired. Family history, as we discussed, celiac disease in his brother, prostate cancer from his father. Unfortunately, his dad passed a couple years prior after a stroke. Allergies, he has this questionable gluten sensitivity, as we discussed, medications not currently on anything. Social history is also relatively non-contributory. He is a non-smoker, drinks maybe once or twice a week at most, occasionally smokes marijuana. He said maybe about once a month. And he has one sexual partner, which is his wife. And I'll get to what you're waiting for, which is the physical exam. So our set of vitals, he is afebrile, temperature 98.1, normotensive 140 over 100, heart rate 88, a respiratory rate 18. He's satting well on room air, 98%, and his body weight is 70 kilos with a BMI of 24. He's in no acute distress. He has a normal neck exam, no cervical lymphadenopathy, normal cardiovascular exam, lungs are cleared to auscultation bilaterally, and his abdomen, it is soft. He doesn't have rebound tenderness, but he does have, mild tenderness to palpation across all four quadrants, most notable in the left upper quadrant. His skin, he's got petechial macules with a few palpable purpura on the distal lower legs. Otherwise, also involving the trunk, bilateral upper and lower extremities, the buttocks with coalescing macules on the trunk and arms. It spares the palms, soles, and face. He's got no joint effusions. His extremities are warm and well perfused. His neurologic exam is intact, and he has a normal psychiatric affect. And I will jump to the picture before we stop again. So pictured here, I have this is his left leg, this is his left arm, and this is his flank. So do you want me to stay on this slide or go to the physical exam slide? Your preference. Okay, so now that we've given you the patient's full history, set of vitals, and the physical exam, I guess first, I would like you to comment on what you think about the rash and how you approach a rash. I know rash is a very broad term that is you probably see in all sorts of notes. And then after that, we can discuss how your interpretation of the rash affects your differential.
You're right. You should probably go back. You should go to the rash slide.
Yes.
So this rash to me looks like there's some petechiae and there's some purpura, maybe also some ecchymosis, but mainly purpura. Your exam said palpable purpura, right?
So on the leg, it's described as palpable purpura, and then it's described as macules on the trunk and arms.
Got it. Okay. So like petechiae and purpura, like they usually, when I think about it, I think about obviously vasculitic etiologies. Small vessel vasculitis is the first thing that comes to my mind whenever I see like a petechiae purpura. Granted, I've ruled out like a really low thrombocytopenia and the patient is not coagulopathic. Those would be the first thing that I would think of. This rash to me, like especially involvement of the dependent areas, basically because of high pressure areas, that's how the RBCs come out of the vessel, blood vessel extravasation, which causes them to not blanch, is pretty typical in cases of inflammation and endothelial damage. So those are the things that I would think about. Obviously, like common causes, like I said, and then in our world, small vessel vasculitis. If you'd shown me like, with the celiac disease code history, if it would have been like a dermatitis herpetiformis, that would be like a vascular really intensely itchy pruritic rash, mainly in the extensor surfaces, maybe buttocks and maybe scalp. So sparing of the face and, soles and palms, they point towards that direction. Obviously, involvement of the palms and soles, there's only a few diagnoses that does that, as everybody knows, like Rocky Mountain spotted fever, secondary syphilis, and stuff like that, which probably is this not the case given his history. But yeah, I think that's all I can think of with this rash in particular.
Awesome. Thank you so much for clarifying that. Just for our knowledge, can you also explain what the difference is between a blanching and a non-blanching rash?
Sure, yeah. If you put pressure and it goes away, that's blanching. That's usually when there is dilatation of the blood vessel, like for example, a wheal or allergic response. But then where there's definite vessel damage and extravasation of RBCs outside of the vessel, then that is non-blanchable. So even if you apply pressure and it doesn't go away. So that is a definitive, like usually when I want to distinguish between an urticaria or let's say like urticarial vasculitis, that's an important distinction because urticaria will blanch, it'll go away within 24 hours, but the other one would not.
Great. And for reference, this was non-blanching. And could you also explain what your thought process is versus like a macule versus a palpable, like a papule, like a purpura?
Yeah, a palpable purpura, again, to me, when I think about it, the damage is done and the RBCs are out. And then there's so I think that's where you palpate in that area. So there's like a definite inflammation, vessel damage. So palpable purpura for me is almost diagnostic of a vessel damage and inflammation in that area, unless you have anything that you can rule out, like I said, coagulopathy or really severe thrombocytopenia.
Great. So at this point in time, could you remind us what your leading diagnoses would be on your differential?
I would say some kind of small vessel vasculitis, probably as a result of this viral infection, maybe triggered by it, would be my leading diagnosis at this point. There's many causes of small vessel vasculitis. I don't think I can narrow it down just yet, but given the mention of epistaxis and nasal congestion, I would think of ANCA-associated vasculitis also. And then with the involvement of the gut, I would think about mesenteric vasculitis also, especially since you mentioned GI bleed and abdominal pain. And that can be because of, again, ANCA-associated vasculitis, IgA vasculitis, and also like connective tissue disease associated vasculitis, like lupus associated mesenteric vasculitis. So those are the things that I would probably are at the top of my differential diagnosis list.
Wonderful. Let's hop into some diagnostics. So thank you for addressing your differential and additional thoughts already. For free, I'll give you some basic labs and then I'll let you, free form, you decide what you want. So this is our metabolic panel, as well as some LFTs. Pretty much non-contributory here. I know there's a little bit of a increased ALT. And then I also got a CBC for you as well as with a diff. Is there anything here that's particularly, catching your eye?
So I like that the creatinine is near normal, although I don't have a baseline in this individual, but looks normal. So that makes me feel a little bit better because usually with vasculitis, I worry about kidney involvement and any concern for kidney failure. Not sure what to make of the little bit of calcium elevation here. I'm going to ignore that. The ALT 83 might just be a part of like a general inflammatory systemic picture. I'm not sure that really guides me to any specific way. The mild leukocytosis is probably just a part of the overall inflammatory picture. It's not like too high to suggest like a bacterial infection. This level can be associated with any inflammatory condition. Same with the platelets being 475. The ANC, again, similar. This, I think overall, I like where my diagnosis is, but it doesn't really give me anything specific.
Gotcha. Thanks. All right. Now it's up to you. What additional diagnostics would you like?
Inflammatory markers. I would like CRP ESR. I would like a urine and a urine protein creatinine ratio, because I'm interested in seeing if there is any hematuria there, and also to see if there's any proteinuria. I would probably like to get a occult blood also to make sure if the stool was not like clearly dark black, or like there was specific blood in the stools that we could see, because I would want to take a look at that. I would probably want ANCA levels with a reflex to MPO and PR3. I don't think I would want an ANA at this juncture, just because there is not anything in history that points me towards a connective tissue diagnosis. But I would consider that depending on case-by-case basis. Since we brought up the concern for IgA, especially with a recent infection, maybe I would get an IgA level. Sometimes can be helpful, although there's no clear prognostic benefit from that. I think those are what I would start off with.
Great. So this is our board of labs, and you get to pick from them. We can start with the urine to please Dr. Chang. So our urinalysis was relatively unremarkable. And then also urine protein creatinine ratio was done, which was normal. A 24-hour urine protein was started to be collected, but then once this came back, it was stopped. And then urine drug screen was negative as well. Anything from here, jumping out to you, or how does that inform your thought processes?
Makes me feel great.
Okay.
I see that there's no kidney involvement, so we're in the right direction.
Awesome. So in this case, the anemia workup doesn't really apply. Patient's not anemic. But other than that, where would you like to go next?
Maybe room serologies.
Sure. So we have an ESR of 11, a CRP of 3.9, which are both within normal limits. There was an ANA that was drawn, which was negative. ANCA was also negative. MPO and PR3 were less than 0.2. C3 and C4 serum were drawn, and those were within normal limits. And then IgA was drawn as well, which was 224, which is within the reference range as well.
This is great. I mean, since the complements are normal, I'm thinking less of lupus. The IgA being normal does not really rule out IgA vasculitis for me. It was more so to see if it was high. ANCA being negative probably takes me away from ANCA vasculitis a little bit. So I think that's probably going to go down a little bit in my overall differential diagnosis, since this is a pretty generalized presentation. If it's only like ear, nose, and throat, I do expect the ANCA to sometimes be negative, but when there's such a systemic involvement, ANCA being negative, takes me a little away from ANCA-associated vasculitis. The inflammatory markers being normal probably say that, there's not a lot of inflammation, which is great. So I think at this point, IgA vasculitis probably climbs up in the differential for me. Yeah.
Great. Anything else you would like next? Your options are infectious evaluation, and imaging and pathology.
Given the moderate to severe, I think you mentioned left upper quadrant pain, I wonder if there was any imaging done to look at the spleen.
There was some imaging done.
Can we look at it?
Yes, we can. So there was a chest X-ray that was done. It was normal. There was no consolidations, effusions, pneumothorax. We also have a CT abdomen pelvis with contrast. We're lucky to have Dr. Schmidt with us here today. She did her undergrad here at WashU, her MD at the University of South Florida, and then her residency here. And she is just completed her chief resident year. Now she's an advanced abdominal imaging fellow. And your slide should be good to go. And this is the top button. The top one is like the laser pointer, and then you can advance with this or with that.
Okay, sweet. So I'm sorry to disappoint. I didn't actually pull out anything about the spleen because it was very unremarkable, but spleen looked okay. It was normal, not the cause of his left upper quadrant pain. What might be surprising, given that we talked about his left upper quadrant pain, was that in the right lower quadrant here, there's this loop of very inflamed small bowel. So you can see that it has sort of a, I'm going to use this instead of the laser pointer. You can see that it has like a targetoid appearance to the enhancement. So there's mucosal hyper enhancement and then a layer here in between of a hypo enhancement showing just bowel edema. You can see that there's also, there we go. Some mesenteric edema, which if you take, this is the same loop of bowel, just a little bit more anterior in the patient. You can see that this hazy stranding here on the mesenteric side is a little edema throughout there. So this was a focal loop of bowel that was inflamed, but relatively long segment. And then I want to point out that he had an small bowel intussusception. We see these fairly frequently. Small bowel intussusception can be a totally normal and transient thing. So here, what you're seeing is like the outer loop of that like muscular layer of bowel here, and then the fact that there's something in the middle here. As you scroll through, you can see that this is a loop of bowel intussuscepted upon itself. I think it's a little bit easier to tell that it's doing that, like kind of telescoping in here. You can see this outer layer, and then that is where it's telescoping in. So if I just saw one of these without that loop of bowel and not knowing any history, I would just pass it. Most of the time, we don't talk about small bowel intussusceptions if we don't see an underlying lead point or any other finding that gives it clinical relevance. We assume that it's likely physiologic, just transient peristalsis. But this gentleman had a few of them. Here, I'm giving just two representative examples, but here you can see sort of like a hot dog in a bun. Look here, that's another telescoping loop of bowel. And then here you can see this one also, you can kind of see, I'm just showing like the very start of where it's intussuscepting in. And if you went a few slices below this, it would look much like that full like targetoid lesion like this one did. So those were our relevant findings. Focal bowel thickening of a long segment loop in the right hemiabdomen with mucosal hyperenhancement and submucosal edema, mesenteric edema in that segmental fashion, and then multiple jejunal intussusceptions.
Thank you very much, Dr. Schmidt. Sorry, this is our chest X-ray read, which was normal. Okay, so based on that abdominal imaging and the multiple foci of small bowel intussusception, does that influence your differential at all?
Yes. Again, it's not as common in adults, but children have like a really high chance of intussusception when they have IgA vasculitis. I think there was even some board questions that talked about recurrent like appendicitis and children's appendix getting removed, but they ended up having intussusception. So less common in adults, but definitely more common in children. So yes, this again, intussusception makes me think of IgA vasculitis.
Gotcha. If that's your leading diagnosis, or leading on your differential, how would you approach diagnosing that condition?
So for this person, I think we said abdominal pain, palpable purpura. He had bilateral knee pain. He already has like the three main, like a triad for IgA vasculitis. But, if this was a kid, he would probably already be diagnosed with IgA vasculitis. But since this is an adult, I would still be more comfortable if I had a skin biopsy of this lesion, just because the direct immunofluorescence, if it shows IgA and maybe like C3 deposition in the blood vessels, that would make me way more comfortable to call this IgA vasculitis, only because of the fact that this is a 43-year-old adult. And IgA vasculitis, although we don't have any kidney involvement here, they have a higher chances of kidney involvement and higher chances of the kidney function not recovering than a child would. So I think just based on that, and maybe I'm just being cautious as a recently graduated fellow, but I would probably ask for a skin biopsy if I could get one.
Absolutely. We have that for you. We consulted dermatology and a skin biopsy was done. I'll briefly just give you the infectious stuff as well before we go to that. But as I'm sure you imagine, there's nothing super relevant here. RPP was negative, blood cultures were drawn and no growth from there. HIV was non-reactive, acute het panel negative, RPR non-reactive as well. And then we had some additional infectious eval that was done. CMV and EBV antibodies were drawn. IgMs were negative, but IgGs were positive, indicative of prior infection. Rocky Mountain spotted fever titers were also drawn, which were negative. ASO and DNase B were drawn as well. Can you explain to our audience why the ASO was likely drawn, particularly with this patient's presentation? You had mentioned it earlier.
Yeah, maybe like a past streptococcal infection could have contributed and also caused IgA vasculitis. So I think that's why it was probably drawn.
Great. Okay, I'm going to pull up the pathology slides and then Dylan, if you could introduce our pathologist here. We have a punch biopsy of the skin, left thigh, plus immunofluorescence. We have Dr. Kat Williams with us on Zoom, I believe. She's a PGY3. She's the chief resident in anatomic pathology. She did her undergrad at Salem College, MD at UNC Chapel Hill, and her residency here. Please give it up for Dr. Williams.
Okay. Do you want me to share my slides separately so that you guys can see my cursor? Would that be, okay, that works here? Perfect.
You just want me to go?
Okay. I'm sorry, what'd you say?
I can navigate the slides or you can share and use your cursor either way.
No, I think you navigating the slides should work fine. So here we have a 20x view of this punch skin biopsy, and looking at our epidermis first, you can appreciate that it's a relatively normal looking epidermis with some basket weave looking keratosis on top, as we would expect on a skin surface, not too much inflammation within the epidermis itself. But looking down into the superficial dermis, especially around these blood vessels, we can start to appreciate some inflammation that even from this power, hopefully you can appreciate that there looks like to be a mixture of both lymphocytes as well as some acute inflammatory cells and potentially even some eosinophils and histiocytes. Additionally, just under the epidermis, right in the center of our field, you can see kind of this brighter pinkish red color, getting a hint of some red blood cell extravasation within the dermis itself as well. Next slide, please. So looking a little bit higher on the left, we're looking at one of those vessels, and we can really begin to appreciate that there is definitely some mixed inflammation here. We have lymphocytes, some neutrophils, histiocytes, and eosinophils, all really concentrated just around these vascular spaces. And then you can appreciate that as well on the image on the right. And just above it, you can more readily appreciate that these are some extravasated red blood cells, which we see with purpuric type rashes frequently. Additionally, there's also some of these darker looking nuclei are some pycnotic cells, evidence of some nuclear debris mixed in as well. Next slide. And so here I have some representative images of what the immunofluorescence for this patient's biopsy did look like. So on the far left, we have fibrin, and these very bright areas are showing areas of fibrin deposition that correlate with some superficial blood vessels in the papillary dermis. And you can see some of these bright areas of deposition within blood vessels for both IgA and C3 as well. Next image.
I think this is the last image I have for you. Was there another image that I'm missing?
No. I wasn't sure if you wanted me to talk about this part at all.
Please do. Go ahead. Thank you.
Yeah. So overall results for this biopsy were evidence of IgA, C3, and fibrin deposition, specifically in those superficial dermal blood vessels, which is compatible with one of the differentials that has been brought up quite a lot.
Thank you, Dr. Williams. Okay, Dr. Bhandari, just wondering what your final thoughts are, and the next slide will reveal the diagnosis.
Yeah, with the history, the perfect triad, tetrad, the leukocytoclastic vasculitis, and IgA C3, it appears to be IgA vasculitis, probably like a post-viral.
Excellent. Yeah, diagnosis IgA vasculitis, known by its former name as Henoch-Schönlein purpura. She was all over it from the beginning. So just briefly, the patient's hospital course. He got started on Solu-Medrol after the room labs and the biopsy was obtained while they were waiting for the results. General surgery was consulted for management of the intus. They elected for non-surgical management. He was put on a clear liquid diet with just serial abdominal exams. He was discharged pretty shortly after his presentation. He was only admitted for 2 days. He was then discharged on a pred taper for about 12 days. His abdominal pain got better very quickly. By the time he was discharged, he was no longer having abdominal pain. The rash, however, took a little bit longer to resolve. He missed his rheumatology follow-up appointments, so he never saw a rheumatologist after that. I don't know exactly when within that period the rash resolved, but by the time he saw his PCP 2 months later, his rash was completely resolved. So I just have a few teaching points, and I'd love for you to add on if you had anything else. Like you said, IgA vasculitis is most common usually in children. The annual incidence for adults is really low. It's only 14 in per million. And like Dr. Bhandari was saying, typically preceded by URI, often streptococcal bacteria, scarlet fever. I thought this was helpful for me when reading about this was the percentage likelihood for all of the clinical manifestations. Palpable purpura being the most common, but abdominal pain and GI bleeding only in 50% of folks, arthralgias in 60%, and then renal involvement less than 50%. So obviously, if you have IgA nephropathy or a GN, that is defined by kidney involvement, but an IgA vasculitis in itself, not everyone has renal involvement. And like Dr. Bhandari already mentioned earlier, children typically more self-resolving. Adults have a higher risk of having persistent damage to the kidney. So more important for them to be treated if they do have renal involvement. The diagnosis, there's no specific lab tests that will confirm this diagnosis. Like Dr. Bhandari already said, the IgA level does not, if it's high or low, does not determine whether or not there's an IgA vasculitis. The diagnosis is cinched by tissue biopsy and specifically immunofluorescence. And I put this on here, but renal biopsy is rarely necessary for this diagnosis, but will show IgA deposition within the mesangium. I think the management is important to know as well. Children typically are more likely to be self-limited and supportive care. This gentleman would classify in terms of like severe disease in terms of skin involvement, but not with renal involvement, which is why he got course of steroids. And then immunosuppression with like B-cell depletion and alkylating agent is a little controversial. In adults, though, with renal involvement, they typically end up getting a course of either cyclophosphamide or rituximab, specifically because of the risk of persistent nephropathy. So were there any other learning points for our residents that you have for us?
Even steroids is a little bit of a controversy, but I guess with the intussusception in this case, and the rash, I think glucocorticoids make sense. In terms of like maintenance, there isn't a clear consensus. DMARDs have been trialed. Rituximab usually only trialed if there's like a recurrent case. And like you said, if there's a kidney involvement and it has shown some promise, but these are all, there's not a whole lot of data to guide any management. Obviously, if there's proteinuria, ACE and ARBs are probably going to be the best treatment. Otherwise, usually a self-limiting disease. The only caveat to that, as you mentioned, is the kidney involvement and the kidney, like the progression of disease, especially in adults. Thought of as different diseases before, but now considered part of the same spectrum is IgA vasculitis and IgA nephropathy. So like, I think kidney involvement is probably makes or breaks the management here. Otherwise, symptomatic management is something that is probably done for the most people.
Thank you so much. The only thing I didn't put in here was for proteinuria control. Also, nowadays, folks will typically get SGLT2 as well, in addition to the ARB.
Yep.
But thank you so much. Give it up for Dr. Bhandari. You nailed this case.